Dear viewers, recently I discussed driving pressure and transpulmonary pressure during invasive mechanical ventilation separately. In this video, I am going to discuss plateau pressure, how this pressure parameter is useful during invasive mechanical ventilation and what are the limitations and limit. I am Dr. Sunil Garg from Essentials of Acute Care. Plateau pressure is the end inspiratory airway pressure and is measured just after airflow has ceased, means when the flow is zero. This is static measurement because of absence of airflow, so resistance of the circuit and airways does not play a role. Therefore, plateau pressure is a logical surrogate measurement for mean alveolar pressure. In a healthy adult undergoing mechanical ventilation with normal lung compliance, plateau pressure is low and usually in the range of 5 to 15 cm of water. It is an independent risk factor for increased mortality. How we calculate or measure it? Plateau pressure may be measured using the inspiratory hold function on the ventilator or in a volume control mode, estimating it from the pressure time curve when an inspiratory pause or hold is used. Remember, there should not be any spontaneous efforts, so patient must be on sedation with or without paralysis. Plateau pressure may be calculated from the respiratory system compliance and the tidal volume. Divide the tidal volume by compliance and the value you get is plateau pressure. Patients with alveolar disease like patients with pneumonia, cardiogenic pulmonary edema, acute lung injury or ARDS have poor lung compliance and plateau pressure is typically much higher in this state. High plateau pressure reflects either worse disease severity or inadequate recruitment of consolidated lung, and it is an independent risk factor for increased mortality. The main limitation of plateau pressure is that compliance is not equal in all regions of the lung. The degree of alveolar distension in healthy regions of the lung may be significantly greater than that in heavily diseased lung regions at the same plateau pressure. The single plateau pressure value reflects global picture of respiratory system including lung and chest wall. So when lung is heterogeneously involved as in ARDS, it may not provide information what exactly is happening in different lung regions. We must understand that the interpretation of plateau pressure considers the compliance of chest wall in addition to lung. So whenever plateau pressure is high, it may be due to impaired lung or chest wall compliance or both. Moreover, the value of external PEEP is also a part of plateau pressure. So if you increase PEEP, plateau pressure may decrease or increase depending on whether increase in PEEP recruits the lung or causes overdistension. With volume control ventilation, high peak and plateau pressure may be due to reduced lung or chest wall compliance, whereas high peak but normal plateau pressure is indicative of increased airway resistance. So what affects plateau pressure? Plateau pressure is indicative of alveolar pressure at end inspiration and is influenced by respiratory system compliance. It means compliance of both lungs and chest wall. So if compliance decreases either of chest wall or the lung, plateau pressure increases. It is unknown whether there is a specific plateau pressure that is safe. Ventilator-induced lung injury is minimized by limiting plateau pressure to less than 30 cm of water. So ideally all patients should be managed with a plateau pressure less than 30 cm of water unless there is a marked decrease in chest wall compliance. When chest wall compliance is reduced, as in cases of obesity or abdominal compartment syndrome, a higher plateau pressure may be tolerated. Thanks for watching this video. Please do not forget to subscribe to this channel. If you have any feedback, suggestion or comments, please write down in the comment section box. See you in my next video on some interesting topic.